All right, let's talk about hypothermia. This is going to be a Scurry County EMS training video. It's for internal use. We're going to cover guidelines with regard to hypothermia. So let's get started. What is hypothermia? Well, hypothermia is basically the situation where your core body temperature drops below normal, generally below 95 degrees. So we operate in that 96 to 99 range, right in there, usually 98.6, or in that 98 range, right in the middle there. We can get cold for whatever reason. Our core body temperature can drop for a variety of reasons, and we can drop below that 95 range and we become hypothermic. That's just what it means. It means loss of core body temperature. It can either be loss of temperature or the fact that our bodies can't generate enough heat to compensate or maintain our own temperature. So it could be that there is a external loss of temperature or an internal lack of conduction of temperature or creation of temperature. So that will lead to hypothermia. Hypothermia can start out mild and work its way to moderate into severe, and severe hypothermic patients can be very critical patients. And in some cases, they can be very difficult to treat. Mild hypothermia generally is fairly easy to treat. So let's look at what happens as our body temperature drops. We react to cold certain ways. As we get colder, our core body temperature drops. We'll hit the 97, 96 range. Our body, we start to shiver, we shake. Our body's trying to generate more heat. So we feel that cold setting in. As our temperature continues to drop, we get below 96, getting below 95, 95, 94 range, 93. We start to get confused, disoriented. We have trouble walking or sitting upright in some cases. We can't focus. We forget things. As the temperature drops, we get around that 92, 93 range. Short-term memory can't move to long-term memory. So it's very similar to a head injury patient. You may ask them a question, they may answer it, or they may ask a question, and then a couple of minutes later, they may ask the exact same question because they're not able to process that long-term memory. They can't move data into long-term memory, so they forget things. They can't focus. They're very disoriented. As we drop into the low 90s, closer to that 90, 91 range, we have significantly reduced the threshold for dysrhythmias. So we are very susceptible for cardiac arrhythmias, especially if you are already predisposed to certain types of dysrhythmias or arrhythmias. Your body can go into that. This drop in temperature will generate a trigger. So if you have episodes of atrial fib, or if you have frequent PVCs, they can get considerably worse, or you can go into atrial fibrillation. So cardiac dysrhythmias or arrhythmias are going to be we're going to be more and more susceptible to them as we drop into that 90 range. We get below 90, our muscles don't want to work like they're supposed to. They contract. It gets hard to use your hands and your feet. It's very difficult to stay upright. Muscles get very rigid. They stiffen up. Functionality decreases. As we continue to drop in our temperature and we get close to that 86, 87 range, we get extremely lethargic to the point of becoming obtunded. So our patients are going to be very difficult to rouse, very difficult to get a response from. They may not respond well to painful stimuli. They may be completely unresponsive or nearly unresponsive. And as they hit about 86, 85, most of them will slip into a coma. They'll be comatose or completely unresponsive or very minor response to any kind of stimuli. And it will, as the core temperature continues to drop and drop, their skin becomes pale as more and more blood is shunted to the core body, and the heart rate has slowed and blood pressure has dropped. Their skin's going to become more pallid. They'll have a loss of muscle tone as they get into the upper 70s, where they become very flaccid. The heart rate has slowed considerably. And when they get into the low 70s, the human body is very, very near death. And it's very difficult to distinguish between the person being dead and not. You're going to have a difficult time finding a pulse. It's going to be really hard to discern if they're breathing. They may be only taking 1 or 2 breaths a minute, and they may be very shallow breaths. Their pulse may be very, very difficult to find. You can try auscultating heart tones. That may be very difficult to hear. It's going to be very difficult when they get around that 70 range to discern their life signs. And then when they drop below about 69, 68, they get down in there. Human beings just die. They just can't tolerate that kind of decreased core body temperature. So what causes hypothermia? Well, the most obvious cause, of course, is cold. Exposure to cold or being wet, any kind of liquid on our bodies that is below body temperature or cooler than body temperature is going to pull heat away and help radiate heat. We function like a radiator. That's why we sweat the way we do in the summertime. We function like a swamp cooler. So we any liquid on our body serves that same purpose. It's going to pull heat out of our body and cool us like a radiator. So if a person's wet, we need to make sure they're dry or get wet clothing off of them. So wetness or that moisture will help pull heat out. So will exposure to cold air, cold wind, cold surfaces, direct exposure to ice, in the wintertime. We can lay on a cold surface for any lengthy period of time. How many of you have fallen asleep in the bathtub in a nice warm bath and you wake up 30 minutes later or 40 minutes later and you're freezing because the water got cold and you're laying against a cold surface, you've got cold moisture on you, everything is pulling temperature away from your body. So cold is the most common cause, but it's not the only cause. It's just the one that commonly comes to mind. There are metabolic causes, such as issues with your thyroid. Hyperthyroidism can cause your body's inability to regulate its temperature properly. So you may not be able to generate that heat. Or in some cases, you may generate too much. Same with glucose. Decreasing glucose. The body can't, if glucolysis doesn't occur like it's supposed to, we don't generate body temperature. We don't generate those BTUs that we're supposed to create heat. So as our glucose drops, so does our temperature. Drugs and medications. There's a number of drugs and medications out there that can affect our body temperature or our ability to maintain temperature. Opioids can affect our ability to maintain our temperature. Alcohol. Everybody says, drink alcohol and I feel warm. Well, alcohol is an illusion. Alcohol actually does the opposite. It doesn't heat you up and it doesn't make you warmer. It makes you feel warmer and gives you the impression that you're warmer, but it actually does the opposite. Alcohol will actually help speed up the process of lowering your body temperature. The reason is your body can only process alcohol, a limited amount of alcohol, so it has to get rid of alcohol in other ways. And so you're going to breathe it out, you're going to sweat it out. Your body has difficulty maintaining temperature as it is, the more intoxicated you are, and then your body's also going to shed heat when it's trying to shed the alcohol. So, but it's going to give you the impression that, hey, everything's fine. I feel good. There's an assortment of medications that can affect your ability to maintain core body temperature. Metformin is one. Metformin overdoses is very difficult for people to maintain their core body temperature during those overdoses. Tricycline antidepressants can affect the central nervous system and can cause drops in core body temperature because your body loses the functionality to generate that heat. There's another assortment of central nervous system effects we can get from a stroke, can limit our ability to generate body temperature or maintain our body temperature. Alzheimer's disease and Parkinson's, these are two diseases that can affect our ability to maintain our temperature. Spinal cord injury and head injury. These people with TBIs are not going to be able to maintain their body temperature well. Many cases because, you get spinal cord damage or a TBI. A lot of times people lose vagal tone. They're not going to be able to constrict their blood vessels, so the blood vessels have a tendency to stay dilated in many cases, especially if they go into shock. So it's very difficult for them to retain heat because they're going to be radiating it out. As opposed to it's not just an effect of directly affecting their ability to generate heat, but their ability to retain it is going to be affected by trauma. And it can be any kind of trauma. It doesn't necessarily have to be head trauma or spinal trauma. Patients with other significant forms of trauma, such as long bone fractures or multiple traumatic injuries, if we allow their body temperature to drop, then their body can't address those injuries as well. It's proven that not maintaining their body temperature in traumatic situations, especially where they're losing blood volume or going into shock, not maintaining their body temperature has a negative impact on their outcome. So trauma patients, we absolutely want to maintain their body temperature. Burns, the body's trying to address burns. It dumps a large amount of plasma a lot of times if you've got a large surface area burn. And so that wound area becomes this giant radiator for heat. So they lose body temperature through the radiation of heat from those burn injuries. Sepsis. We get patients that are septic. We have septic patients, they may be running a fever, or septic patients that can't maintain body temperature due to infection. As we get older, we just can't. I'm getting older. We can't maintain, body temperature the way we used to. There were days that nothing made me cold. Now I get cold chills all the time. It's ridiculous. Being malnourished or dehydrated can affect your ability to generate body temperature. We've got to be burning fuels to generate, whether it's glucose or fats. We've got to be burning fuels to generate body temperature, to generate heat internally ourselves. We've got to have muscle movement, and our metabolism has to be moving properly so that we can generate body temperature, generate heat of our own. So being malnourished, we can't fuel that system. So it's very difficult for malnourished people to maintain their body temperature. So adults are going to present to us a certain way. They may be just shivering. If it's a mild case of hypothermia, they may just be shivering, and they may be hyperventilating a little bit, and they just can't stop shivering or shaking. As it progresses, they're going to get confused, disoriented. They're going to lose coordination. They're not going to be able to walk properly. You'll notice that in the gait. Being awkward. They may have trouble sitting up or maintaining an upright position. As it continues to progress, their skin's going to get colder to the touch. Generally cold and dry usually, unless they're wet from something and that's what's causing them to be hypothermic. Their skin's going to take on a bluish tint as blood is shunted back into the core. As we progress, you may get irritability or irregularity in the heartbeat, whether it's PVCs or some arrhythmia That's going to generate an irregular heartbeat. We're going to see that in our vital signs. Pulses are going to get weaker. The colder the extremities, the weaker the pulses are going to get there, to the point we may not find a pulse. And even in cases of pulses closer to the body, they may be very, very difficult to locate, such as carotids or femoral pulses. And as we get into about the low 90s, right around the 90-degree temperature range, pupils dilate and they become fixed and dilated. So how do we treat it per our guidelines? A lot of it's common sense. It really is. And most medical care is common sense. There's no reason to push common sense out of it. If a person is cold, we warm them up. That's always going to be our primary it's going to be our primary goal throughout the whole amount of treatment, or our whole episode of care with this patient. Our goal is always going to be to warm them up. We need to get their body temperature back to a normal range. Now, how aggressive we get with that is going to be real dependent on what their situation is. We want to try to keep them calm. We don't want them to be moving around a lot. We don't want them getting really agitated. We want to keep them flat or with their head just slightly elevated. We want to wrap them up in blankets to try to retain what body heat we can, and we can even add additional blankets or heating sources to start bringing their body temperature up. We don't want to lose it, but we need to also add to it. That can be with ready heats or hot packs. Ideally, if you're exposed to any kind of water sources, you definitely don't want to be using electric blankets. They're a little too questionable in some cases as to how well they heat up, but hot packs or blankets are great. The ready heat devices that are out there are wonderful. If you're in a hospital setting or in certain EMS services, you may have a bear hugger, something that uses hot air to generate basically a hot air blanket on the patient. External heat sources are great. Turn the heat up in your ambulance. Remember, you're trying to treat your patient. It may be a little uncomfortable for you, but the goal is to bring the patient's core body temperature up. Hot packs are great. They will last for a certain period of time. We can utilize them. Just be careful with some of the hot packs and things like the ready heat and all. These are things we don't want to put directly on a patient's skin, because you can run into cases where you can burn the patient, and we don't need to be giving our patient first-degree burns because we're trying to warm them up. If the patient is conscious, oriented, and can safely protect their airway, warm fluids are acceptable. Made with love. Warm fluids do work to help heat the patient internally. Do not give the patient anything by mouth if there's any risk of vomiting or any risk that the patient is not able to protect their own airway. So someone in mild hypothermia, where we wrap them up in a couple of blankets and give them something warm to drink, that might be an ideal solution. And put them in a warm room, that might be an ideal solution. And in many cases of mild hypothermia, that may be as far as you have to go. Some kind of warm electrolyte drink or something non-caffeinated. It's ideal that if you're going to give the patient any kind of fluids orally, make sure they're non-caffeinated. The reason for that is, remember, they're hypothermic. We've reduced the threshold for arrhythmias, so we don't want to give them stimulants. We don't want to agitate that or add to that. So remember, only consider fluids, oral fluids, if the patient is safely able to consume them. IV fluids is going to be your second best thing. IV fluids work great. Most of us have IV warmers. I know at Scurry County we have IV warmers. We maintain them around 101 to 102 degrees, so our fluids are kept at that temperature at all times. So we're able to start an IV or two. Ideally, we want to start a couple of IV sites, and we can administer fluids through warm IV fluids. And remember, these IV fluids may be 101 to 102 degrees. But by the time that fluid runs through the drip chamber, through the IV tubing into the patient, it is dropped to somewhere closer to body temperature. So you're going, even on a warm day, you're going to lose temperature from the bag to the patient. So there may be situations where you have to warm the bag up a little bit more. And there's a variety of ways to do that. But you may have to warm the fluids a little bit more to get them in the patient at a slightly higher temperature. But we don't want to be injecting fluids into a patient that's above that 100, 101 range. Okay? So be careful with that. You don't want to overheat your fluids. But if the fluids are below, even room temperature fluids are close to body temperature. If you've got someone who's below 90, even fluids at 96, 97 degrees are going to help bring their body temperature up. The goal is we're putting warm fluids into them internally and trying to heat that core up. We want to monitor their core temperature as often as possible. Every time you take a set of vital signs, every 5 to 10 minutes, you need to probably go ahead and check their temperature as well. We need to make sure that what we're doing and any of the treatment regimens that we're providing are moving that patient in the correct direction. That we're bringing their core body temperature back up. If you can do constant core body temperature measuring, we can with the Zoll. You can drop a nasopharyngeal or esophageal temperature probe down and monitor the patient's core body temperature constantly. You can also take and place that temperature probe. If you can't drop the oropharyngeal airway, you can place that temperature probe in a little plastic sleeve and stick it in their armpit. And cover them up. And that'll give you a rough estimate of their core body temperature. And then, of course, you want to check your tympanic if that's all you've got, or oral if that's what you've got access to. But we want to monitor their core body temperature as frequently as possible, so we know that we're moving in the correct direction. We also want to monitor all their other vital signs, including EKG, including end tidal, and we want to consider doing a 12 lead. We need to know what our patient's vital signs are anyway. That's something we should always be monitoring. But because these people, if they're hypothermic, they're going to be really susceptible to irritability. Cardiac irritability, we want to monitor EKG. There are things that you're not going to be able to see on the EKG. Most monitors, if you're monitoring a single lead like lead 2 or V1, or if you're just using a single lead monitor, it's not in diagnostic mode. I know the Zolls are that way. If you're just monitoring a single lead, you're not in diagnostic mode. Which means there's a lot of filters and amplifiers on, so what you're seeing on the screen may not completely be accurate to what's really going on. That's a good reason that we need to run a 12 lead, because we get a diagnostic view of the heart from multiple viewpoints. So you've got a hypothermic patient, they're really susceptible to cardiac dysrhythmias or arrhythmias. We want to make sure that we run that 12 lead if we've given the opportunity. We also want to monitor their CO2. As they get colder, metabolism changes, things slow down, and we may not get gas exchange normal gas exchange. So we want to monitor their end tidal, because that will tell us if we're getting good gas exchange. And we can keep an eye on that, and it's real-time information. So don't forget to monitor CO2 as well. We want to monitor their glucose. Now, adults have the ability, unless they're diabetic or there's some other condition going on that affects their glucose, most adults will maintain their glucose fairly well, unless they just don't have any reserves. But if even normal non-diabetic patients who've been shivering for a while or have been cold, if it's a slow progress through hypothermia, they may burn up and use up a lot of their glucose and maybe even tap into more of their reserves than normal. So it may not be uncommon for their glucose to be low. If they're a diabetic, they could easily run through their glucose stores. So if they're able to take anything safely by mouth and their glucose is low, and by our guidelines is below 60, we can give them instant glucose if they can swallow appropriately and maintain their airway. If not, we have D10. For an adult, it's 100 cc's bolus, titrated to effect after that. So we have access. We tap in to piggyback it in on the IV that you're running the warm fluids in and administer the dextrose. And then follow up blood sugar evaluations. Airway. Airway is always going to be important. From the moment you make contact with a patient to the time you hand your patient off, their airway should be monitored by you at all times. Now, most of us do this subconsciously. As soon as we walk up, we're evaluating how well the person's breathing, what their airway status is like, what their circulation, their mental status. We're doing all that at the same time. We're taking in that full picture. But on severely hypothermic patients, we may have to really get close to evaluating. We may have to listen really carefully. We may have to watch very carefully. We're going to have to really focus on evaluating their airway status. Do not hesitate to give them oxygen if they need it. We want to maintain oxygen saturation between that 95 and 98, 99 range. We want to keep them above 94. And we can give them a nasal cannula. You can use an arm rebreather, whatever is needed. You can support ventilations if needed with a BVM, or go ahead and take their airway if necessary. They may be in that state where they're not quite obtunded enough or unresponsive enough that they still maintain a gag reflex. You may aggravate that by inserting an airway, such as an iGel or an intubation. So you may have to sedate this patient. And remember, if they're hypothermic, they may not respond the same to sedatives. In some patients, it's not going to require as much to push them on down further. And those sedatives may stay in their system longer because they may not get metabolized as you would normally expect. So it may not seem to take as much to push them down, but you may have a prolonged effect or even an additive effect later as they start to warm up, because some of it may accumulate depending on what you're giving and how you're giving it, and then later it may hit them later, and so they may be more sedated than they were initially. So just understand that when they're very cold, and if we do have to use any kind of sedatives, that we may not get the same response. So be prepared for that. Whether it means you have to do more or whether you have to do less, just be prepared and monitor your patient. Keep in mind, inserting an airway, one of the things about our patients when they become hypothermic, is they become very susceptible to agitation, movement. We want to keep them still, we want to keep them calm. Because we've reduced that threshold for cardiac irritability, we can easily stimulate them into a dysrhythmia or into an arrhythmia. We can stimulate them right on into VFib just by moving them if they're cold enough. Those patients that are below 86, we can easily stimulate them right into cardiac arrest. So we want to do things very carefully. Shoving an eye gel down their throat is going to be stimulus. So we want to be careful with every adjunct that we utilize. We want to be careful poking and prodding on the patient. We want to be careful moving the patient. Just the act of moving a severely hypothermic patient can be life-threatening. So advanced airways can agitate your situation. And there may be situations where you might need a little bit of sedative before you secure that airway, even if they're borderline. So just keep all that in mind. This is a big picture. This is not something that is, as they get more severely hypothermic, it's more and more difficult to treat them. We have to slow down and be very careful with these patients while still trying to maintain their stability and warm them up. So I mentioned 86 degrees a while ago. When the patient gets below 86 degrees, when their core body temperature gets below 86, it may be very difficult to find a pulse on them. They are going to present as if they're dead. There's going to be barely any registry. I mean, you're barely going to be able to register them breathing, and you may not find a pulse on the patient. In some cases, the only way to see the hearts even beating is with an ultrasound, which we do not have on the ambulance at this time. But we get below 86 degree core temperature, we need to be really, really careful with them. And if we get to them and we don't believe they're breathing and we can't find a pulse, don't just jump into CPR. If we have someone that we believe is that cold, then we want to try to confirm their core body temperature. If we can't find a pulse, they're not breathing, we want to get them on the cardiac monitor before we get too aggressive with them. Quickly put them on the monitor. You can do it with the pads very quickly, or you can put the 4-lead on, but we want to put them on the monitor. And if they've got an organized rhythm that would normally be generating a pulse, then we don't want to do CPR on them yet. We want to try warming them up. We want to try warming them up and improving their oxygenation. But we want to monitor them very, very closely. We want to monitor that EKG. We want to monitor if they're responding. Let's say they're very bradycardic. We can't tell they're breathing, but they've got a sinus bradycardia or a very bradycardic rhythm like that, particularly in narrow complex bradycardia, and we start warming them up and that heart rate starts to improve a little bit, then we know they're responding to us. We start supporting their ventilations, maybe with a nasopharyngeal airway and a BVM, start supporting their ventilations, their oxygenation. We should be able to see, if we're monitoring that patient closely enough, we should be able to see positive changes. If we're seeing positive changes, then that's letting us know that that patient probably has circulation. We just can't feel it. The heart's probably doing its job. We just can't sense it with our capability. But we need to watch that very, very closely. So if you've got an organized rhythm and they're below 86 degrees, it's preferred we don't jump right into CPR. We want to try warming the patient and treating the patient and seeing if we get some kind of response from them. Now, if they go into a unorganized rhythm, VFib, or if they're systole, then we'll go ahead and initiate CPR. If they don't meet any other criteria of not starting CPR. No other indicators of obvious death or anything that would impede us from starting CPR. We're going to go ahead and start and do regular CPR. The thing is, if they're below that 86-degree threshold, it's going to be different. We're going to start CPR. We're going to put the pads on them or put the monitor on the patient. It's going to be pads no matter what device you're using, whether it's an AED or the Zoll. We're going to put the pads on, and if it is a shockable rhythm, VFib or VTAC, we're going to go ahead and shock the patient one time. That's it. One time. If they're below that 86-degree threshold, we're only going to shock them once. Then we're going to initiate CPR and ventilate the patient. We're only going to do CPR while we warm the patient. We're not going to give any medications if their core body temperature is below 86 per our guidelines. So we're not going to jump into epi. We're not going to jump into amiodarone. The goal is to get them up above that 86-degree range. So we got CPR going, we're ventilating the patient, we've got an advanced airway or secondary airway in place, and we're warming their core body temperature if we're actually doing a cardiac arrest. And we're going to do CPR. And once we get their core body temperature up above 86, then we'll start initiating. We can shock the patient again if necessary. We can initiate our epinephrines per guideline, as to whatever method that you're going to utilize, whether you're doing the push doses or the dirty epi, and the amiodarone. If we've had a shockable rhythm and we've shocked the patient, then we'll look at our amiodarone. But we're only going to do this after we've gotten their core body temperature above 86. You may go a while in a cardiac arrest trying to get their core body temperature back up, utilizing heated blankets, utilizing warm fluids, utilizing a warmer environment. It may still take, depending on how cold they are, you may be coding for 15, 20, 30 minutes before you can get their temperature up, just doing CPR and ventilating the patient, until you get them above that 86 range and can initiate additional treatments. We're going to keep going until we get them above 95. So we're going to continue working and coding these patients, and we've coded patients for 40, 50 minutes, an hour, some cases more than an hour, trying to get their core temperature up to that 95 point. Now, per our guidelines, we're going to go ahead and transport these people. We're not going to just code them on scene. This is one of those cases where we do need to go ahead and transport this patient. Do it carefully, do it safely. We do have guidelines to transport these patients, code 1, while we're coding them and trying to warm them up. But our goal is to work their temperature up and try to get that response back from them. Some patients can go a lengthy period of time hypothermic, and we can still get them back with minimal damage. So we need to continue that resuscitation efforts until we get them to 95. Remember, they're not dead, so they're warm and dead. Our medical direction gives you orders to stop. Other than that, we're going to get them, we're going to do CPR only and ventilate until we get them above 86. Then we're going to, from 86 to 95, we can initiate normal cardiac arrest guidelines. And we can consider cessation of those guidelines after we've achieved that 95 or we've consulted with medical control. So now pediatrics are going to be a little different. Not a whole lot, but a little bit. So pediatrics, particularly toddlers and infants, they're going to present to us a little bit differently. They can't tell us what's wrong. They can't verbalize. It's difficult to tell if they're confused or disoriented because they can't communicate the way an adult would or an older child would. So we have to pay attention. One, we're going to check their body temperature and see if it's below normal. If we're below that, if we're in the 95, 96 range and dropping, then we know they're hypothermic. They're going to present probably with a weak cry. They're going to be lethargic, real low energy levels. They're not going to move. They're going to be flaccid. Their skin is going to be cold to the touch. But unlike us, where we have a tendency to get purplish, they'll have a tendency to get reddish. Whereas an adult will get a little more purple or gray. A child, a pediatric, especially an infant, will get kind of reddish. They may have difficulty breathing or struggle to breathe. And they may not be consuming food as their temperature drops. So they're just going to present like just a weak, lethargic baby who's not responding well. And their levels of responsiveness will decrease as their core body temperature drops. Now, some treatment variances with the pediatric. Once their temperature drops below 90, whereas an adult, we consider 86 to be critical. They get to 86, that's a critical patient. And we get a pediatric that's below 90, that's a critical patient. They can't handle the temperature variances as much as an adult can. So we need to handle them with care, move them carefully. Their body temperature drops below 90, we can easily push them into a cardiac arrest situation. So we want to handle them very carefully. When you're monitoring their glucose, children, especially infants and small children, they burn through their glucose very quickly. So we want to constantly check their glucose. Every time you take vital signs, about every 10 minutes, you need to be checking their glucose. If you're taking vital signs every 5 to 10 minutes, you probably need to check their glucose about every 10 minutes. We want to constantly check their glucose. We're going to administer our D10 at 2 cc's per kilo in boluses. And if their glucose is dropped or it's not back where we want it in a few minutes, then we'll give another bolus. Remember, these are pediatric, so we'll watch our fluids, watch our fluid boluses, and watch our of all types. Okay, so keep that in mind. We don't want to run an IV wide open on an infant. We're going to give our 10 cc's per kilo boluses and our 20 cc per kilo boluses, plus our 2 cc per kilo boluses of D10 as needed. And do those as frequently as we need to try to warm them up. But be careful. We can easily overload an infant or a toddler. So keep that in mind. And we can use the same techniques, warm blankets. If they are altered, if they're not severely hypothermic, and they're altered, parents are very important. Unless there's a justifiable reason not to have parents there, have parents there. Children that are confused or disoriented will still generally respond to their parents. So wrapping them up and letting their parents hold them if that's possible to try to generate that body temperature. If it doesn't impede your care, utilize parents or at least have them present with the child. That will help a lot, especially if the child's altered. Similar to adults, if they drop below 86 and we have to code them, in cardiac arrest, we're only going to shock them once at 4 joules per kilo, and we're going to withhold meds till we get their core body temperature up above 86. So it's just going to be CPR and ventilation, the same as it would be for an adult. All right, so that covers what I wanted to cover on our hypothermic guidelines. And I hope you have a little understanding of treating our hypothermic patients. It's that time of the year. So we should be seeing that as fall and winter moves in here in West Texas. We should start seeing these types of patients more and more frequently. So be ready For those of you that are Scurry County EMS employees, in the description below, there should be a link to a test. If you take the 10-question test, then we will see about getting you CE and getting that sent to you. It only applies to Scurry County EMS employees. Anyone else, I hope the video was somewhat educational, and have a nice day.